Welcome, everyone, to our SHAP webinar, State-to-State Exchange on Health Insurance Exchanges. This webinar is funded by the Health Resources and Services Administration, HRSA's, SHAP program through a contract with us at NASHP to provide technical assistance to the State Health Access Program, or SHAP. I'm Ann Gauthier, a senior fellow at NASHP and the project director of our HRSA contract, and I'll be today's moderator. For those who don't know, the National Academy for State Health Policy is a nonprofit, nonpartisan, non-membership organization dedicated to helping states achieve excellence in health policy and practice. NASHP provides a forum for constructive work across branches, both branches, the executive and the legislative, and agencies of state government on critical issues facing states. We are delighted that we are expecting over 650 listeners from all 50 states. We hope this webinar will allow us to share information and ideas with each other as we move forward. The moderator always gets one of the most fun jobs here, and that is to do some housekeeping before I turn to substance. So with that, this webinar is supported, as I think you know, by a web-based interaction and phone lines. Hopefully, you have all logged in through the ReadyTalk website in addition to listening to me by phone now. The ReadyTalk login link was sent to you when you registered. We will ask you that if you are on the phone, if you put your actual phone on mute during the conference. You should all see a chat box on the bottom left. At any point during this webinar, you can ask a question by typing it into that chat box. This is really a great feature, in particular if something the speaker is saying is unclear, and we can see your question and we'll actually try to get clarity from the speaker as soon as possible. We will also be using this feature for the Q&A towards the end of the presentation. You will not be able to ask questions through the phone lines, not quite sure that we could manage so many of you. So, I'm delighted to dive into the substance here. As you know, states are busy laying the groundwork for health insurance exchanges, a major part of implementing federal health reform legislation. A handful of states started working on exchanges even prior to the passage of the law as part of the work funded by HRSA's State Health Access Program, or SHAP. This webinar is an opportunity to hear directly from two high-ranking state officials, Trish Riley of Maine and Jane Cline of West Virginia, who are innovators in this area and also happen to be SHAP grantee states. Today we'll hear about where they currently stand on key exchange design issues such as whether to consider a regional exchange, governance, eligibility and enrollment, tools to achieve affordability, and stakeholder engagement. We'll then have an opportunity for our audience to ask questions directly through the chat feature, as I just noted. I want to stress, though, that both states will have a new governor in January. Therefore, the issues that they talk about are not their final decisions, not by any stretch. This is a chance to hear how they've been thinking about the issues and what their considerations are, something that we think is just as informative as some of the decisions themselves. We will begin today's webinar with a presentation by my colleague Sonia Swartz, who will provide an overview of the issues around some of these key choices that states have to make regarding exchanges. I'll introduce Sonia and she'll do her presentation, and then I will introduce our two distinguished speakers from the two states, and we're going to proceed in an interactive question and answer format until we get to the Q&A format with them until we get to the open Q&A where you all may join us. So, with no further ado, let me introduce my colleague Sonia. She's a program director at NASHP, and she manages some of our technical assistance for the SHAP project. She works mostly on coverage for the uninsured, Medicaid, and state and national health reform. Sonia joined NASHP in 2005 after 3 years as a senior health policy analyst for Families USA. She holds a BA from Middlebury College and a JD in Public Interest Law and Policy from the UCLA School of Law. Turning it over to you, Sonia.
Thanks, Anne. Chris, would you mind going to the first slide? Before I get started today, I just wanted to say an explicit thanks to Chris Cantrell, our research assistant, who many of you know out there. He's our research assistant on the SHAP program funded by HRSA, and he's also a key contributor to our statereform.org website, and he collaborated with me on these slides that I'm about to share. I'm going to talk about 5 key design issues as states start to consider the look and feel of their exchanges, one at a time, and these are the same key issues that you're going to hear are kind of the basis for the interview that will happen later of our state officials from West Virginia and Maine. So the first design issue is, what is your state's overall vision for the exchange? The Affordable Care Act, which I'll refer to on this call as ACA, really does give states quite a lot of flexibility and a lot of different tools to have different visions for how their health insurance exchanges will work. Some of us think that exchanges can really do a whole lot. We think effective exchanges can give meaning to the affordability standards in the federal law and provide a force for efficiency and reduce costs and an orientation toward quality in the insurance and health delivery sectors. However, these outcomes that a lot of us want don't come naturally or automatically just from the creation of a state exchange. A state really does have to be active and even at times aggressive in administering the exchange for these ends to come to be. In terms of the flexibility that ACA gives, it really allows states to decide whether they want to do a state exchange, a sub-state exchange, a regional exchange, or a federal exchange. One example is that California decided to run an exchange themselves. They believed there that it was the state's responsibility to do so. We're hearing little bits of rumors and gossip from states about what they're deciding, and we're going to hear more from West Virginia and Maine about some of those their decisions about along those lines. ACA also allows states to establish either one exchange or 2 exchanges. 2 would be one for individuals and a separate exchange for small businesses called the SHAP exchanges. Proposed legislation we peeked at in Pennsylvania is interested in creating a separate small business exchange from the individual exchange, and California is also planning to run 2 separate exchanges. But in California, they're planning to report to their board in 2018 recommendations for going forward about whether it should continue to be a separate exchange for individuals and small businesses or a merged exchange. The law also allows states to include all plans in their exchange, all health insurance plans, or select only plans that meet certain standards. We're going to talk more about this issue in an upcoming slide about tools for affordability. Next slide, please. The second key design issue we wanted to talk about, and I'm just going to wait for the slide to come up. Sometimes maybe with all these listeners it's a little slower. Here we go. Is governance. ACA allows for a few different governance models that I wanted to lay out. The first option is an exchange can sit in a new or existing agency under a governor. An example of this model is Utah's exchange. It lives in the Office of Economic Development in the sub-office of Consumer Health Services. The second option is the independent public utility. This one seems to be the sort of most popular so far. California and Massachusetts have both decided to use an independent public entity that will be governed by a board. The composition of these boards can vary state by state. So far as we've seen. In general, states appoint members from the legislative and executive branches of government to these boards. In California, for example, the 5-member board will elect an executive director for the exchange. Option 3, which is the third bullet here, is a state-established nonprofit. This one has not come to existence yet, but we do know that Oregon is looking into it. They would create a state-chartered public corporation that had a consumer advisory board to provide input to their governing board. The recommendation on this choice for Oregon is due to the legislature next month in December, so we'll learn more about it then if they choose to proceed with that. Governing entities in exchanges can be set up to perform a wide variety of functions. I think in Oregon, one of the advantages that they saw to creating a nonprofit board was to not necessarily have to follow all the state procurement practices. That may be able to be a little bit more nimble and fast-paced without having to do that. But governing entities can do a large variety of things. They can request detailed information from health plans. They can serve as a contracting agency for health plan participation or for contracting with an eligibility system, and they can monitor the exchange appeals process for enrollees in the plan. The third design issue I wanted to cover relates to eligibility and enrollment systems. Here, ACA does have some pretty specific requirements for what states need to do. States state exchanges need to, under the Affordable Care Act, determine if an individual is a citizen or a lawfully present immigrant, determine if an individual meets the income and coverage requirements for subsidies, federal tax credits, or for, I guess I'll stop there. Third, they need to determine if an employer's coverage is treated as unaffordable. Fourth, they have to determine whether to grant an exemption from the personal responsibility requirement or the penalty when an individual does not obtain insurance under the mandate. And last, they have to evaluate and determine eligibility for applicants in Medicaid, SHAP, and other health programs. But most of the rest outside of that is left to states. There are a couple of big questions here that states face. The first is, will your state create a single door for enrollment? Will it be one system or some sort of interface that links separate systems for different programs? The next is, who will help the system and where will it sit? Will it sit in the exchange? Will it sit in Medicaid? Will it sit with a private contractor? We've seen lots of states' discussions and choices here that are pretty diverse. And the next big question is, how does this system interface with Medicaid and CHIP and other human services programs? Will it be integrated vertically and be accessible across all health programs? Will it be integrated horizontally? And will other human services programs be connected to it? And last, the biggie in the short term is, how do you find the resources to develop these information technology resources? Will you apply for the big IT systems grants that have recently been announced? Will you try to maximize your Medicaid enhanced match of 90% to help build part of this infrastructure? Those are some of the questions. At our NASHP meeting in October, there was a presentation from Wisconsin that's gotten there's been a lot of buzz about it. In Wisconsin, they shared with us that they want to have one front door for all health programs, the exchange that incorporates both the small group and individual markets, Medicaid, CHIP, and leverage also their existing public-facing enrollment website called Access. There have been a lot of different webinars, and I know SHADE Act did one and NASHP did one to show you Access live online, and so this has been of a lot of interest to other states. On the back end, they would then integrate their system and use data to gather information about the enrollees and limit the amount of individuals had to enter for their employees and their families on the back end. So there would be some automatic data that would be integrated into the system so people wouldn't have to provide all the data themselves. The system would be, it's pretty ambitious. The system would be vertically and horizontally integrated. It would provide immediate automatic termination of eligibility, so real-time eligibility determination. It would allow people to choose their health plan, choose their payment options, and even choose their communication options. Do they want to receive a text message? Do they want to receive an email? Do they want to receive a phone call? Pretty ambitious system we heard about from Wisconsin, and lots of interest in it. Design issue 4 is, what tools should a state use to achieve affordability? Here's another place where states really do have a range of options for how the exchange would operate. They can go from an active purchaser model, in which the exchange really runs more like large employers do when they use market leverage and tools to manage competition to negotiate product offerings, or it can operate as an open marketplace model where the exchange really is more of a clearinghouse, open to all qualified insurers and relying on basic market forces to generate product offerings. Again, ACA also gives lots of flexibility to consider using the exchanges as a way to reward or encourage high-value plans and other delivery system and payment reforms. It does require pricing quality rating as a core function of the exchange, which is another tool states can use to achieve affordability. The guidance that HHS issued November 18th, and I didn't want to use this webinar, I'm not HHS, and I didn't want to use this webinar to walk through the guidance, but the guidance makes it clear that states have flexibility to respond to local market conditions and take actions to facilitate competition among plans on price and quality. And it also says that states have flexibility to provide consistent regulation both inside and outside the exchange and to take additional action to prevent adverse selection under one section of ACA. 1311E1B is that section. So again, there are some key questions here. Where will your state fall on the spectrum for exchange? Will it be a market organizer that offers all qualified plans, or an active purchaser that actually selectively contracts with plans or even negotiates with plans? Are you thinking about ways to reward or encourage high-value plans or affect other delivery system reforms like promoting ACOs or possibly medical homes as part of your exchange design? Are you considering value-based benefit design? What about other tools you can use to prevent adverse selection? I feel like it's Passover here with my 4 questions. In terms of one state example here, in California, they really focused in here on the adverse selection issue, and because we have their draft legislation, we know a little bit more about that than we know about other states. A couple tools they're hoping to use to avoid adverse selection are they're going to offer identical products inside and outside the exchange. They're going to offer exchange products at all 4 actuarial values, bronze through platinum. The only plans that will be allowed to sell catastrophic policies are those who participate in the exchange. And lastly, the only products that will be available outside the exchange are to people who aren't eligible via the exchange. And in California, this is an issue because of immigrants without documentation who won't be able to purchase through the exchange. So that was a big question for them. The 5th and last design issue I will cover before I hand you off to our wonderful state speakers is stakeholder engagement. Section 1311D6 of ACA requires exchanges to consult with a broad range of stakeholders in carrying out their activities. It tells you states that have to do this. It's not particularly prescriptive about how to do this. It says that exchanges need to undertake aggressive and multifaceted outreach to inform the public of their services and coverage options. So this is more when you're getting toward actually enrolling people. And then the law also says that successful exchanges will work closely with consumer advocates, national insurers, community-based insurers, and potential new market entrants, different sort of emerging insurance product lines, to create a competitive climate that will offer purchasers a range of product offering. This is a fun one to talk about because I recently had a chance to interview Lorez Meinhold from Colorado about their consumer stakeholder efforts. They're really doing a pretty robust job there, and I wanted to talk a little bit more about that. We actually posted a blog about this on statereform.org about 3 weeks ago, and I just wanted to say that because I feel cool just saying that we posted a blog about it because blogs are new to us at NASHP, but we're really proud of the blogs we've posted so far on statereform.org. Some of the tips from Colorado focused on reaching consumers and small businesses. She really offered us about 10 tips. I'm just going to highlight a few. The first is to involve a facilitator in meetings with consumers and small businesses. The second is to create background information so everyone attending the meeting starts from the same place. Obviously, it's hard for consumers who don't do this as their day job like we do, health policy wonks like we do, to contribute to a conversation. So having some background information really does help them contribute. Also, by developing key questions you want stakeholders to focus on at each meeting, you can really focus the conversation and feel like it's more productive. Another tip from Lorez was to create a record of stakeholder input. So have a note taker at the meetings and make sure that future decisions draw input from this discussion and this log of what the discussion was about. She also, along these lines, said to be as transparent as possible about how you pick the facilitator, how you pick the place for the meeting, who was invited, all that stuff. Be as transparent as you can be. And make sure to keep up this work as decisions are made. This stakeholder involvement doesn't just start and end as you're planning. As you roll out options, as you test your interface perhaps for your exchange, as you test the enrollment and eligibility system, all these are really great opportunities to involve stakeholders and be part of your testing and rollout efforts to keep people into the input loop. Well, thank you so much for your time. I'm going to transition back to Anne so she can introduce our wonderful state speakers, and I'll be on board at the end for questions.
Thank you so much, Sonia. That was a terrific overview of the issues and some great state examples that we could show that some other states were thinking of. We now have the opportunity to dive in much greater depth with our 2 expert states, our expert panel here. And what we're going to do is first I'll introduce them, and then I'm going to ask a question about each of the issues. And we're going to go in something, a fairly traditional alphabetical order by state. So we will start with Maine, and we'll go next to West Virginia. We make no statement at all about where they are in their thinking. You'll see as we go through this that each of them has spent some time in different areas where they've made some preliminary decisions, or where they've laid out their analyses and the kinds of considerations that are going to have to be thought through in order for the next administration to actually make those choices. So starting with Maine, let me first introduce Trish Riley. Trish serves as the Director of Governor Balducci's Office of Health Policy and Finance, leading his effort to develop a comprehensive, coordinated health system in Maine. Quite frankly, Trish was the principal architect of Dirigo Health Reform. I'm also delighted to say that before joining the Governor Balducci's administration, Trish was formerly executive director here at NASHP, and she was continued as president of its corporate board from 1989 until 2003. And I've introduced Jane Cline, who was appointed West Virginia Insurance Commissioner on January 15th, 2001. So both of our speakers have had a fair amount of tenure in their current positions in their states. In addition to her responsibilities as Insurance Commissioner, Ms. Cline serves as President of the National Association of Insurance Commissioners, that's the NAIC, as well as the Chair of the Management Committee of the Interstate Insurance Product Regulation Commission. During her tenure, she's held various leadership positions with the NAIC, and I know she is here in Washington, D.C. today in conjunction with the announcement of the administration's issuing the medical loss ratio rule this morning. We wish we had known she would have been here earlier, then she could have been here in our Washington, D.C. office with us. I'm delighted to have both of our speakers here today, wherever they're sitting, in order to give us their views on exchanges. So turning to our first question, really the overarching question, our executive committee, when they met right after the passage of health reform, came up with 10 priorities that states needed to think about if they were to successfully implement health reform. And the number one priority was be strategic with the exchange. So I ask the two of you, what is your overall vision of the exchange? What's your current thinking about it? And really importantly, what are your considerations in these decisions when it's ultimately made? Are you thinking about having one or two exchanges? Are you thinking about statewide, sub-state, or regional, and other options? Let me ask Trish if you would please comment first. We'll move to your slide. Thank you.
Sure. Thanks, Ann. Let me just really quickly point out that we in the Baldacci administration will develop a plan and an analysis of the HCA and a series of recommendations using a steering committee of state officials and a 20-person stakeholder council that's bipartisan. And we'll have a public hearing in December. We'll talk more about stakeholder engagement and make a recommendation by the end of December. But we're quick to point out that we have not only a change in governor, but also a change in both the House and Senate here. So we clearly recognize that what we're about to walk through with the group is our preliminary thinking, not yet final recommendations of that group. But given that, we do have general agreement from our own steering committee and from our stakeholder council that in Maine, a state of about 1.3 million people, we envision one exchange statewide that combines both the individual and small group market, much as our Dirigo Health Agency now operates today. We think there's real administrative efficiencies in pooling the individuals and small group. And there's a real intersection that we've found from our experience of individuals who move in and out of small business employment and self-employment and indeed the Medicaid program. There's general agreement, too, that the exchange ought to be a robust one, that it really should be a player in the marketplace. We have a parallel activity underway on payment reform, and see and envision an exchange that's more than a clearinghouse, but that really is a market player to try to advance more cost-effective care, higher quality care, and have a broader role of health reform. One of the worries as we think about what the exchange will look like, there are about 1 million people under 65 in Maine. Nearly half of them meet the income criteria for subsidies. So potentially, and because Maine already has a very widely expanded Medicaid program, potentially we could see significant buying power in an exchange. One question that will need to be resolved is as we look at our small businesses, given that the median income of the state is about $42,000, we wonder, will small businesses continue to operate? Will the 2-year tax subsidy be adequate, or will we see a migration into the individual market? And I think that, again, speaks to why it's important to combine the individual and small groups in one exchange.
Thank you, Trish. I know this is not on your slide, but because we're going to come to it in the West Virginia, have you done some preliminary thinking about whether it would make some sense for Maine to join with any other states in New England to do something of a regional exchange with multiple states?
There's some legislative interest on that. I think there's a real disconnect between a legislative perspective and an executive perspective here. I think the regional notion is extraordinarily difficult to think through. While we do want to work regionally to think if there are economies of scale around marketing and IT, I can't envision a regional exchange given, even with the insurance reforms that are more standardized, you still have provider networks that are state-based. Governance issues in a regional program are very difficult for me to get my arms around, because how will 5 or 6 or 2 or 3 state legislatures yield their authority, and should they, to some kind of regional entity? And I think even with the again, with the similarities in the insurance rules that will be in effect in 2014, you still have different Medicaid programs, different mandates. Some states might choose to expand their mandates and pay for them in the exchange. Others may not. And you see there'll also be some real significant differences between the individual and small group markets. What if one of the states wants to merge the 2 markets, which we're intrigued by here, and others don't? It just seems to me there's so much complexity in establishing exchange. It's hard to think about regionally before you. It's a little bit like running before you can walk. That is not to say, though, that there aren't regional collaborations that will be very important and where there might be some real harmonic convergence and ability to get some efficiencies.
Thank you. Then why don't we turn to Jane Cline in West Virginia and hear your thoughts about the vision for the exchange, regional exchanges, and whether you'll do a statewide, et cetera.
Thank you. I will actually build upon some of Trish's thoughts there too. But the legislation does allow states to jointly form regional exchanges, and this option can be especially attractive to relatively small states. For a regional exchange to exist, however, each state must permit such operation, and HHS Secretary must also approve the regional exchange compact. There are both benefits and barriers from the regional exchange approach. The benefits include creating a larger risk pool, which could benefit consumers by spreading risk of a larger group of consumers, creating larger markets by having a larger pool of consumers and pulling from carriers in 2 jurisdictions. A regional exchange could potentially promote greater consumer choice in the market. A regional exchange would also find potential savings through administrative efficiencies of having more consumers utilizing exchange services. But there also is portability across state lines, which is particularly makes sense in states that have a large number of citizens crossing state lines for employment and medical treatment. In West Virginia in particular, the majority of the state's population lives in counties that border other states. In other words, 60% of our population is within an hour of a border. Having said that, there are also barriers to having a regional exchange. Some states may not be apt to join with states that have a less healthy pool. This is particularly a barrier, again, to a state like West Virginia. This issue could be mitigated through actuarially sound regional rating processes and practices, however. There are other concerns such as licensure, as different states have different procedures for some aspects of licensing, consumer advocacy, rates and form approval. So it is also important that we protect state sovereignty as we find out ways to improve the health insurance market. There's also the state benefit issue, which could present a problem in that state sovereignty over mandated benefits could also serve as a critical barrier to regional exchanges. There would also be governance issues that would have to be worked out in a regional exchange, and states would have to agree on the structure of the regional governance. And risk adjustment may also be difficult between the states, and that states would have to develop some type of reciprocal agreement between the payer claims databases and have some type of information sharing agreement between carriers of the different states. But there is also a possibility where we could do administrative agreements where states do not have to share the risk pools or even borders to work together on the health insurance exchange. In other words, adjacent and non-adjacent states may find savings, particularly on IT infrastructure, by entering into compacts to share exchange administrative functions. The benefits would be perhaps to leverage down vendor costs, share best practices, and share maintenance costs. But again, there are barriers in that as well, and that would include the state autonomy, coordination of exchange strategy, and the barriers on state procurement laws. So West Virginia is actually exploring the regional exchange and administrative agreement option. We specifically outlined in our planning exchange grant the need to study from policy and actuarial perspectives. Conversations regarding regional exchanges have already taken place at some of the NAIC zone meetings, and the NAIC will likely be developing a white paper addressing the issue in the coming months.
Thank you. So clearly it's on your agenda, but there are such a number of pros and cons that it's going to take both what the numbers say as well as all of these other considerations before you come up with a final decision. So let's turn to
And I'm struck that there's a third choice, which is the federal exchange, and it strikes me that there is in the law the potential for states to decide not to proceed, and I think we all need more information about what a federal exchange would look like and how that might work.
And that's very accurate. There is the third option, which I didn't touch upon.
And neither did I. That's why these things
You're absolutely right. There is that third option. Is it a correct impression that both West Virginia and Maine, in your thinking, was that it would be your preference to do a state exchange? Trish, maybe you might, though, comment just a little further on what it would be about the federal exchange that might make you make a different decision.
Well, I think all states, instinctively, we think it ought to be state-based, and provider networks are local, and there's such differences between and among states. But that said, I think we do need to know what a federal exchange would look like, because I think policymakers, before they make the decision about how to proceed, need to know what all options are. And at this point, there's not any information about what a federal exchange would look like and how it would work with state-to-state Medicaid collaboration and so forth. So I think it's more an area where we have a wait and see to just see what a federal exchange would look like, because as you think about the cost and the work of putting together these exchanges, that's an option that some policymakers would want to know more about.
Jane, is that your perspective in West Virginia as well, or are you pretty much marching down the path of designing one of these types of state-based exchanges?
Well, I agree with Trish that I think that from my perspective, having it more local is much better for West Virginia citizens than having something at the federal government. But it's much like many of the other pieces of the reform package. Until we know what the rules and the requirements are going to be, it is sometimes difficult to make your final recommendation. But I think that still is important for us to continue to review and analyze all options and continue to move forward as we wait for additional information from HHS.
Thank you. Well, let's move to our next question. It's a similar one, which is what is your current thinking about what will the governance structure be? As Sonia pointed out, there are three basic options: a state agency, the public-private option, or the known as a quasi-public agency, often governed by a board, or a nonprofit agency that the state establishes. What's your thinking about this in terms of the pros and cons of the various choices for your state? And if you're thinking about an entity that would have a board, what is your view about the industry, particularly agents and brokers, and their representation on the board? Let's go to Maine's considerations first. Trish?
Yeah, we have thought through the three options here and landed on a place. We looked at the nonprofit option first. It's obviously the area where that's least influenced by political environment. It's clearly the most nimble for all of us who know what it takes to work through state procurement and human resources rules and the regulations regarding how much you can pay people. You could potentially attract a different level of staff potentially if you could pay more and could afford it in the costs you want to secure for your administration of an exchange. It's not government, and some people may trust it more as a result. And there are traditionally private functions around insurance that may be easier to carry out in a nonprofit. That said, the flip side is it's very much the hardest entity to ensure that state priorities are carried out. It's the furthest away from accountability. It may be more difficult for a nonprofit to coordinate among and between state and federal agencies. We do think there would be difficulty in sharing confidential information. It's challenging enough sometimes between Medicaid agencies and other access programs, as we've experienced. And government still remains responsible for carrying out the act. So the governor and legislature with a nonprofit would have really the least accountability and the least ability to make changes that they felt were appropriate if all the authority were vested in a nonprofit. So we then looked at the next slide, which is, what about an existing government agency? Could we put an exchange in an existing government agency? The pro there is that obviously it ensures that states' priorities and goals are being met. It's probably the easiest coordination with federal and other state agencies and makes data sharing easier. It's obviously a place of significant transparency and accountability. The state would know. Policymakers would be able to hold this entity accountable. And a director would likely be appointed by a commissioner within an agency or by the governor directly or through some process created by the legislature. The downside of an existing government agency, first and foremost, is in this budget environment, we thought it was highly unlikely that a new agency would be created and that we couldn't really justify those costs. Therefore, it would likely be an agency that would be led by a commissioner that serves at the pleasure of a governor, and that gives you accountability as a governor, but also less security compared, for example, to the nonprofit. Inside a government agency, it would not have a diverse governing board. Obviously, one of the concerns about placing an exchange within an existing agency is, will it get lost? Would it be as a subunit under an agency? How would it get the attention it needs, particularly at startup? We recognize, regrettably, that there are still stigmas affiliated with being part of a governmental agency. It's a place as a governmental agency that would make it very much influenced by the political environment, and it would be less nimble as it would have to follow state procurement, human resources, and other rules. Which led us to the third option, which is where we, in our preliminary thinking, have landed, that the exchange ought to be an independent and quasi-state agency. We have significant experience with that, given that the Virgo Health Agency, our health reform entity, is a quasi-state agency run by an independent board appointed by the governor and approved by the state senate. So when we looked at the option of an independent agency, we thought that it was a better site for state priorities. It still reflects a state agency viewpoint. It's easier to coordinate with federal and state agencies. You have better accountability and transparency. It's independent, but still a state agency responsible for that kind of transparency. You could appoint a governing board that was composed of people with technical expertise. That board would be appointed likely by a governor and legislature, so it would have that accountability. The executive director would serve at the pleasure of the board. It may have some flexibility from some state procurement and human resources laws. And we think it would be better able to interact with private sector than a fully government agency. And we have some experience that would reflect that in our Dirigo experience. The downside is, even in an independent state agency, there are some problems sharing confidential information. It may carry a stigma with consumers, as it's still viewed as a government agency. It may be somewhat influenced by political environment. It's still a state agency with the review and oversight. It's less able to ensure accountability and transparency to state government than a full governmental entity. And to some degree, the executive and legislative branches have less control, given that they've vested that in a board of directors. But again, this is the area where our thinking to date suggests that we think this is the best option for Maine.
Thanks, Trish. Let's turn to Jane in West Virginia and to talk about your thinking at this stage of the game with respect to governance.
Thank you. Governance has been a topic that we have been discussing at great length. Currently, I mean, we were trying to determine whether we thought it would be best as a state agency or as a nonprofit, or, you know, again, turning back to the federal government. But having said that, we know that regardless of what the governance structure looks like, we must engage with the governor's office in that an exchange will not exist as an island and should be coordinated with other health reform initiatives in the state. We also recognize that the insurance regulator is going to have a significant role, and that states should be very careful to avoid regulatory duplication or complication between the exchange and the regulator, and state regulators will still be performing a number of functions, including licensure, certification, rates and forms, market conduct, consumer services, etc. Medicaid and CHIP offices should also be engaged in that the exchange must determine both eligibility and enrollment. There are also issues regarding continuity of care, quality initiatives, and presumptive eligibility that must be addressed. Also, a state social service agency should be engaged. Not only is there a potential to make referrals to consumers regarding social service programs, but in some states, Medicaid and CHIP enrollment even take place in the Social Service Bureau, as is the case in West Virginia. Another core component of social service programs is that it is traditionally social service staff that serves as the front line for consumers in county offices. And finally, public health and other organizations engaged in quality and management of vulnerable populations should be appropriately engaged. As such, after careful review of the exchange governance options, the offices of Insurance Commissioner will recommend governance of the West Virginia Exchange, suggesting that it should be attached to the insurance regulator. First, as the insurance regulator in West Virginia's market, the OIC and its staff have years of experience in the central subject matter of the exchange, including existing infrastructure, which could provide crucial regulatory and administrative support to the exchange. This infrastructure includes, but is not limited to, rates and forms, consumer services, agent licensing, financial conditions, and market conduct. The offices of the Insurance Commissioner, however, also recognizes the importance of maintaining a clear distinction between the OIC's primary role of insurance regulation and the exchange's more narrow role. To achieve this end, the exchange should be given a high degree of autonomy through an exchange governing board. Our rationale behind that is that with the state authority, the state is in better position to engage stakeholders and make state-oriented policy decisions. We also believe that having an exchange in a state agency with appointed board gives citizens a degree of accountability through the executive branch, and also having an exchange in an existing agency means the costly new bureaucracy does not have to be created. Having an exchange with the insurance regulator means that regulatory functions of the exchange can be performed in line with existing regulatory operations, and it also means that carriers do not have to deal with dueling regulatory agencies. Having a board that is supported but independent, in other words, we recognize that we would need to have a firewall between the board and the regulator, which allows the board to make policy decisions without creating conflict of interest for the regulator. We have an effective model within West Virginia that already exists with our Access West Virginia, which is our current high-risk pool. It has an independent board and is located in the OIC for the purposes of administrative streamlining. This office has performed admirably and is streamlined, yet independent governance serves as an excellent template for the exchange.
Thank you. I think that even from these two sets of thinkings and the way that the two of you have laid out the pros and cons so clearly, particularly as you've been thinking about them in your state, that would lead me to predict that assuming we have 50 state-based exchanges, an assumption I'm not making, I would predict that they're going to look somewhat different. And you, like states, if you've seen one exchange, perhaps you've seen one exchange. These are two very different approaches, but all carefully thought through in terms of at least the pros and cons. I recognize, again, that this is a proposal in both cases, and it's not the final decision. So having slogged through that second really critical decision, let's move to the third of 5, which is how will you coordinate eligibility and enrollment for the exchange with other programs, particularly Medicaid. Again, we seek your perspective and insights on how you're approaching this critical decision for your states. A single door for enrollment? Are you thinking about one system or some type of interface that links separate systems? How will Medicaid interact with other programs? Both have mentioned already today the importance of linking with other programs for the customers that may be eligible for other benefits. What type of eligibility system and where is it housed? And if you're ready to say at this stage of the game, because they are due in only about 2 or 3 weeks, are you thinking about applying for one of the federal IT innovator grants, either alone or perhaps in conjunction with another state? So again, let's head north, and Trish, if you would begin, that would be terrific.
Happy to do it. Let me begin by saying that the innovator grants are an example of where some kind of regional collaboration short of a regional exchange makes sense to us, and we are in conversations with other states in New England about ways to work together on some kind of a system that would take Massachusetts' experience, our own here in Maine, the experience in Vermont, where we've been actively engaged in access initiatives, to see if we can't work together and find some efficiencies in working together in the IT space. The bigger issue of how we see this connection of eligibility and enrollment is one we're still grappling with, of course, but a model that intrigues me is to think differently about Medicaid. What happens, I think, is we think about the exchange in one silo and the Medicaid program in another, recognizing that we've got to integrate them, but it strikes me that we now have a new Medicaid program. Under the ACA, for the first time, we have finally and completely delinked welfare and Medicaid. That's been underway for a long time. That delinking is complete. With the creation of the modified adjusted gross income for everybody from 0 to 400% of the poverty level, you have one eligibility standard for all folks. You have subsidies for everybody from 0 to 400%. Those up to 138 will get Medicaid. The rest of them get the subsidies. We recognize there's lots of churning that occurs as people's income changes in and out of Medicaid. There will be the possibility of families who have different family members in Medicaid and in subsidies. Subsidy structures change. So our interest is in a front door for that eligibility, recognizing that it's not important where you get your subsidy, either through the tax credits or through Medicaid, but that you come in to a very professional, slick, streamlined exchange with easy information available to you that's very private sector oriented and gets people information quickly and easily. That said, we recognize the importance of integrating Medicaid eligibility, and Maine does have a very significant integrated system with social services that's one-stop shopping. So we see the front door of the exchange getting people simple information, simple access to their eligibility for subsidies. For those who are identified as potentially Medicaid eligible, they would simply cascade behind the closed door, unknown to the client, into the integrated delivery eligibility system. That said, there'd also be no wrong door. Someone who came directly to the integrated eligibility system would then be funneled back to the exchange as well, or have their eligibility determined there as well. So we see that as an interesting way to think about almost two systems, but that work together. And that, of course, will take a significant IT investment. We want to build on our current capacity. The Medicaid eligibility system is integrated. It's really quite refined. It does need some modernization to comply with the ACA, and it needs to continue, importantly, for other Medicaid populations, which every state will experience, particularly along the elderly and disabled. We currently have a significant experience in eligibility and enrollment. The Dirigo Health Agency has many of the qualifications and experiences envisioned in an exchange. It has a website and a calculator for subsidies. It does subsidy eligibility and determination. It links to Medicaid, and it's really developed an added exchange capacity thanks to the SHAP grant, now administering vouchers for any insurance company in Maine for part-time workers. So I think that's, in broad brush, how we see an exchange working in Maine.
Thank you. West Virginia, you have a different experience. It sounds like you do have some experience in your high-risk pool that's very different from the Dirigo Health Agency. What's your current thinking about the eligibility and enrollment functions and how they will integrate or coordinate? Jane?
Well, as a quick overview, we recognize that the health exchange eligibility rule, that the exchange must inform individuals of their eligibility for the state's Medicaid program, CHIP, and the federal subsidies, and that the exchange must also determine eligibility for mandated exemptions, for the mandate exemption, but that the exchange must establish a way to apply for enrollment in Medicaid and CHIP, and that HHS will provide single streamlined form that may be used in applying for all applicable state health subsidy programs. We are exploring several eligibility and enrollment options from the IT perspective. The OIC has been in several conversations with constituent state agencies concerning the state's plans moving forward, and planning is still taking place. But among the options would be use the federal IT early innovator option, have eligibility enrollment for public plans take place in a current system with the health exchange through a memorandum of understanding, develop two eligibility enrollment doors, one for public plans and one for the health exchange. The health exchange must develop new IT system for a single entry point. So, and there are also a hybrid of various other options. The technical capacity exists to move forward in a number of directions, and we want our policies driving IT and not the other way around. To ensure cost efficiency, we are engaging in stakeholder engagement, and we'll continue to develop our strategies. We will be working with, again, the stakeholders. We'll determine the core functions of the exchange. We want to maximize federal resources. We want it to be administratively and operationally efficient and ensure that it is seamless and simple for consumers. And in other words, we do not want to compound confusion for consumers, so we know that we will have to thoroughly test whatever option we move forward on. And we have not made a determination as to our application for the the Innovator Grant.
Thank you. I think that given the many options there, maybe a few of you in cyberspace will resonate. Growing up, there was a television program called Let's Make a Deal, and you could pick one door, you could pick another door, and you either got a fabulous prize if you picked the correct one, or you could get a donkey or some crazy thing behind the others. And I think what's clear here is that consumers are not going to open the door and find the donkey or instead of the wonderful sports car that hopefully whatever system they pick, it will be one that leads them to coverage. So it's kind of exciting to think about the different ways that this will proceed, I think. But let's turn, that's tough enough. Let me turn to an equally tough question. What tools are you thinking about employing to achieve affordability? Because after all, I think it's clear to everybody that affordability is the #1 reason why we have so many uninsured. And not only do we need to provide subsidies, but we need to do things to help to restructure the delivery system or to provide incentives for plans and providers to do so that we can sustain this expansion of coverage. What are you two states thinking about? Where are you on the spectrum from the exchange as the market organizer that offers all qualified health plans to perhaps an active purchaser that selectively contracts with plans or even negotiates with them? Are you thinking about ways to reward or encourage high-value plans or to affect delivery system changes, as Sonia noted earlier, such as medical homes or accountable care organizations? I feel like we should have perhaps organized this by switching between the two of you in terms of who started, but we're organized to start again with Trish. So if you could tell us your thinking, Trish, we'd appreciate it.
Sure. We've got two parallel activities underway here. One is the planning effort around the ACA itself. Another is a longer-term legislatively mandated effort around payment reform. And we think there's a real convergence between the two in the exchange so that we can really advance significant payment reform and deal with affordability. Since Maine has the second highest per capita spending in the country, second only to Massachusetts, it's an issue of great concern. We have an individual market like so many other states that's dominated by one carrier, that's very costly, that's very challenging and challenged. And I think our first question, when you think about a new environment in which you meld potentially an exchange that combines small group and individual marketplaces, do you get more buying power? What will be the impact of national plans? And I think this has, again, not had adequate attention. Each state will have two national plans operating in their exchange. For states like ours that has very little competition, particularly in the individual health insurance marketplace, that by itself could bring on some significant competition and could be a real impact in the state. But again, we need to know more about how it will work and what, if any, authority the exchange will have over those national plans. We envision a robust exchange that's a market leader and that negotiates around price and quality. But will each exchange negotiate with the national plans, or will they operate the same across the nation? Those kinds of questions need to be answered, but I think the national plans can't be underestimated as an impact on affordability and choice and competition in the marketplace. We today have a patient-centered medical home demonstration that's a collaborative between Dirigo's Maine Quality Forum, the Maine Health Management Coalition, an employer-led group, and Quality Counts, a nonprofit. It operates in 26 sites. It's all payer with our private insurers actively engaged, our Medicaid program engaged, and we just recently won an award that Medicare will participate going forward, which is pretty exciting. And we think of that as foundational, so that any plan we would envision, and we're not, this is thinking and not recommendation at this point, but we would envision an exchange that would require certain conditions like participation in patient-centered medical homes, like potentially participation in ACOs, depending on what they become, and would connect with the many demonstrations available in the ACA to really go after a much more robust, competitive marketplace. That said, I think one challenging question is, if, as California has identified, and we all agree, there's issues between about adverse selection, if you have different standards and rules and regulations in and outside the exchange. Some argue that you ought to have the same standards in and outside the exchange to avoid adverse selection. If you do that, will you be able to have an exchange that is a robust marketer? What will be its value added if all the rules are the same? How will it be a selective contractor? How will it do the kinds of things one envisions? But finally, we think the notion of pooling and negotiating on behalf of a large group of individuals and small businesses matters and works to bring about affordability. And we know that from our experience in Dirigo. The Dirigo Health Agency pools individuals in small groups. And this year, while all the marketplace has double-digit increases, we have a 0% premium increase, a premium hold in the individual market, and a 2% increase in the small group. So we believe that you can really use your buying clout when you combine individuals and small businesses in a really significant way.
Wow, those are impressive numbers.
It was great, and we're very thankful to our partner, Harvard Pilgrim Healthcare.
Terrific. Let's turn to West Virginia and hear your thinking about mechanisms for using the exchange to improve affordability. Jane?
Thank you. We have listed a few ideas that states may want to pursue in using their exchange to drive down costs. Some are mutually exclusive, and none are without considerable negatives. While an exchange can theoretically drive cost savings, expectations should be managed. The exchange is not the solution to driving down health system costs. While a state exchange can actively attempt to negotiate down plan prices, market stability and solvency must also be considered. It can also be argued that by creating the exchange, carriers will competitively price their plans to garner business, with efforts towards active purchasing could impede. These and other cost-saving mechanisms must be researched and discussed with stakeholders. West Virginia will explore these strategies as part of our planning exchange grant research and development. Given the complexity of many exchange issues, West Virginia has outlined a strategy through our planning exchange grant and will provide the exchange board and policymakers with quantifiable data, impartial economic models, and actuarial assessments. This Gantt chart will give you a better sense of our timeline for the planning exchange grant. A problem we are going to face is the length of time it takes us to go through the purchasing process, and we have already started drafting out several of these contracts, and it is very grueling work. But as far as the cost containment, we recognize that we still have much work that we need to be doing and are exploring various avenues.
Grueling work indeed. Thank you. We're going to move to our fifth organized question here, and I want to let all of our participants know that we will be moving after that to the general question and answer session. So I'd like you to think about your questions. Some of you have been submitting them, but I want to make sure that those who have the chance to submit questions, that you tee it up by typing it in sooner rather than later, because we will run out of time. We'd appreciate it if you'd let us know what state you're from when you state your question. So with that, I think we have a perfect segue to our last issue, which is how will you engage stakeholders? We know that West Virginia and Maine are in a process of engaging stakeholders. I think that others from other states would like to know what you've been doing, what has been particularly helpful in your state to engage the various stakeholders. And I mean not just the consumer groups, but I mean plans, businesses in particular, small businesses, providers, even large employers in your state. Let's go first to Maine. Try something new. We'll go to Maine first. Go ahead, Trish.
We're going north to south.
North to south, that's right.
Our structure, we have the legislature has created a joint select committee on health reform, and will hold 4 or 5 meetings by the time they're done in December that are all public, talking about their policy options. We also, the governor last March or April, through an executive order, created a steering committee that I chair that includes the Commissioner of the Department of Health and Human Services, the Commissioner of the Department of Professional and Financial Regulation, Commissioner of the Department of Administration and Financial Services, the Superintendent of Insurance, and the Director of the Deergo Health Agency. And we've been meeting. We have, thanks to the HRSA grant, which has been invaluable, we have hired consultants who have been hard at work. We do monthly public meetings that are webcast, and which we engage the public as much as we possibly can, and have gone topic by topic through the ACA. We then have an advisory council on health systems development created by the legislature. That's a 20-person stakeholder group, includes 5 bipartisan legislators appointed by the leadership of the legislature. It includes representatives from providers, big business, small business, consumers, etc. And it has held monthly meetings on these topics to engage broadly public input and educate themselves. That group continues even after the change in administration, so will be an important stakeholder group for the new administration as it thinks through what it wants to do and how it wants to take on these recommendations. We'll issue an analysis, so we've done and posted a website on health reform, have all the presentations there, have reached out as broadly as we can. We'll do a draft report synthesizing our analysis of the Act and the opportunities and challenges for Maine, and a series of recommendations, make that public in early December, hold a public hearing on December 14th, and issue a final report to the legislature and to the new administration at the end of the month.
Thank you. Let's turn to West Virginia for the last time in our organized portion of this, our pre-scripted portion of this webinar. Jane, can you talk to us about stakeholder engagements in West Virginia?
Yes, thank you. I think we all agree that stakeholder engagement is going to be critically important and necessary as we move forward in the development of exchange and also the implementation of the healthcare reform in general. We recognize that we must have buy-in from the governor, and the governor's office does have the governor's office of healthy lifestyles and enhancements, and we have been working very closely with them. We also know that we must communicate with constituent state agencies like CHIP and Medicaid and our Public Employees Insurance Agency, and that we must engage with the legislature. And our legislature does have a joint committee that is focused on health and health care issues. We also know that we must engage the insurance carriers and have begun to do that on a regular basis. We have met with the producer community and know that that is going to be an important segment as well, and that we must engage with consumers at every level, the individual, the small group, and the large group, and have also been looking at how we reach out with our Chamber of Commerce's and other business concerns to get at that. And we also will use focus groups to reach underserved demographics, and also recognize and have had some meetings with our hospital association and know that we must engage our medical providers. The scale and importance of the exchange demands that we have a transparent and fully engaged process. So again, we have engaged a large number of stakeholder groups. We have had several meetings with each of these constituency groups and plan to continue these engagements moving forward. We feel it's important to engage key stakeholders in a more direct fashion and allow these discussions to percolate into the broader stakeholder meetings that we are planning for this winter. To keep stakeholders up to date and engaged, West Virginia plans to set up a website where all public documents will be uploaded. This will also give us a presence on the web for those searching about our efforts. Our statewide stakeholder engagement strategy and request for comment will culminate with the development of community of interest groups that focus on exchange policy issues. We anticipate setting up 4 larger groups with a number of subgroups with these more specific tasks. Finally, to ensure that state policymakers are aware of what is happening with the exchange planning and development, we will start publishing a quarterly or monthly exchange update document for our legislature. Legislators will be encouraged to participate in the community of interest discussions, but for those that cannot, we want to ensure that they remain aware of the exchange planning and development efforts. So we are currently in the process of establishing stakeholder meetings and going out throughout our state to set up meetings in individual communities so that individuals don't have to come all the way to Charleston, that will be broader in nature and allow consumers, providers, consumer advocates, legislators, small business people, large businesses to actually attend those meetings, and we will be we're doing that over the course of the next 2 months.
Great, thank you. We now have come to the portion that was promised for questions, open question and answer. We have about 15 to 18 minutes here, so we have a number of questions coming in. I want to let people know that please do submit questions. The chances of us being able to get to all of them is going to be unlikely, so I want to manage the expectation there. What we will do is we will get you answers to your questions subsequent to the webinar for those that we can't get to, and we will post those as well. So let me start here with our first question that's actually a question to both of our panelists asking, when do you anticipate that your states are going to make the final decisions on how to proceed? And importantly, what pitfalls do you foresee between now and then? And I'm going to go in reverse state alphabetical order for this one. Jane, would you like to tackle that first?
Well, we will. We like a number of other states are facing a new governor, only ours was a result of our governor moving on to the U.S. Senate. So we are going to be in the process of obviously doing a lot of education as we move forward with our recommendations, but having been the state agency that was the lead on the exchange and also the state agency that got the planning grant from HHS, I think we're very much ahead of the curve as far as other state interest groups. I would anticipate that there are those that are going to challenge our recommendation that it should be in the offices of the insurance commissioner because they're going to want to see more independence. And my reminder to that would be that we are the consumer protector with respect to regulating the insurance industry, and so we believe that puts us in a good position to do that. Having said that, again, I think it will bring forward questions about independence, but we do have models in place where we have been able to assure people that we are giving the most independence to ensuring that we're protecting the consumers while also regulating the industry to ensure that they have choices and the most affordable products out there.
Thank you. Trish, what do you see as the time frame for decisions, and what do you see as the biggest pitfalls in making those decisions?
Well, I think the challenge will be we have a complete turnover in our legislature and the governor's office. New people coming in to all new, every legislative committee will change leadership. So I think first and foremost we've got new players who are going to have to educate themselves, a new administration who will have to decide what it wants to do, and a challenge of a budget, which I think any new governor is going to find time really taken up in trying to deal with budget issues. So I think the conflicts around budget priorities, needing to learn about what the ACA is, and all new players could challenge our ability to move as quickly as we had originally hoped. It was our feeling that enabling legislation would need to be brought forward this session in order to meet the go live readiness test on January 2013.
And just to build up on that, we do plan to propose legislation during this session, and we don't have the same turnover in our legislature. Both of our houses remain of the same party, and it's the same party as the governor, so we don't have quite that challenge. But again, there will be conflicting and competing budget issues, and but we do plan to move forward this session.
Thank you. I think that that's an important point. I know that those of us who have been thinking about the time frame and what needs to be accomplished between now and the go live date would all say that having legislation passed in this legislative session would be ideal in terms of meeting that time frame, but there are going to be states that may proceed that are not going to be able to do that for various turnover and other reasons in this session. So probably Massachusetts would remind us that they came live pretty quickly after their legislation passed, although they actually did phase in various pieces of their reform over time. So the next question actually is only for West Virginia, and from Rhode Island we have the question, how do you balance being a purchaser with being a regulator in the recommended West Virginia governance model? I think, Jane, you just spoke to that a bit, but if you would talk to that directly, we'd appreciate it.
Well, I mean, we're actually in that situation currently in both responsibilities we have in the area of workers' compensation and also in our Access West Virginia pool. So we are experienced in that. At the end of the day, it's all about what is in the best interest of the consumer. And but having said that, you know, we have independent boards that are appointed by the governor that work with us. You know, we have the Industrial Council in the area of the workers' comp arena, and we have the Access Board in the area of Access West Virginia. So we have subject matter experts and consumers in Access West Virginia that work with us to help guide and make decisions on the direction we go. I think, you know, again, being the regulator of the insurance industry, our primary role is to protect the consumer. And you protect the consumer in a variety of ways, and at the end of the day, that's where we would be focused in any role we would have with the exchange. And it's sometimes a delicate balancing hat, but if you're not balancing the interests of the industry to ensure that they're going to be able to pay policyholders' claims at the end of the day, you haven't protected the consumer either. So, but having input from independent board members is significant and important, and we recognize the need for the firewall.
That's a very thoughtful answer. Thank you. I'm going to switch gears to take another question. And we'll go to Maine first for this one, but the questioner asks about the use of patient navigators, what your thinking is about them, both for eligibility and enrollment or even for helping actually helping patients get access to care, particularly those who are vulnerable and are traditionally more hard to reach populations.
We haven't spent a lot of time on it, and think there's a third issue, which is how much it will cost and what's their relationship with the producer community, except to think that the navigator role is largely one like the Dirigo agency now performs, helping people complete their eligibility, connect with the right choices for them, and really understand the choices and the costs before them. So see it more as an independent function at this point.
Jane, in West Virginia, have you been thinking about the navigators?
We have been thinking about the navigator, and we have also been thinking about the role of the producer and where those may cross, and the fact that you know, we require producers to be licensed and meet educational criteria and tests before they can sell certain products. So should there be consideration to some type of pre-certification and continuing education qualification for the navigators, and how that should cross. Having said that, we know that we have individuals in our Medicaid area that work with consumers on eligibility criteria. I have a consumer services staff that is fully dedicated to supporting consumers and assisting consumers in matters with the insurance industry. So it's where we ultimately end up is going to obviously continue to be a part of our deliberations and continuing to receive input from the various interest groups.
Thanks. we have a question which I think for both states, which is what are your states thinking in terms of whether health plans should be allowed to sell products outside the exchange that are not offered in the exchange?
I think that's a challenge for obviously the way to address best adverse selection is to standardize and to not allow that kind of differential. That said, I think the question is, how then do you make the exchange a robust marketplace that is a selective contractor that does do different kinds of quality and pricing? And I think it's a question we've not yet resolved.
And I would agree with Trish. We're still discussing and trying to sort through all the different nuances about what ultimately does end up in the best interests of West Virginia consumers. Adverse selection is a very real issue, and it's going to have to be accounted for in whichever direction we go.
Adverse selection is obviously a really key point here. We actually have a couple of people that have been asking if to explain it. I think I'm not going to ask either one of you to go there, but to our questioners here, we will point you to some really good resources that will help explain this very serious issue. The basic point is that you don't want to have the high-cost patients winding up, or high-cost consumers winding up in the exchange and having the healthier consumers winding up outside of the exchange. Which would cause all kinds of untoward effects for the insurance market and for costs.
It also invites the issue we haven't talked about, which is the ACA envisions risk adjustment to ameliorate some of those challenges, but we don't know yet much about how to do that and know that it's a pretty costly and complex undertaking. So again, an area where federal guidance will be very, very helpful.
A very, very good point. Let me move to another question. I think we have time for two more. And again, our apologies to this very responsive audience. It's clearly got interest in tapping our experts here. We have from our colleagues at SHAP posed this question. Both the speakers have talked about the exchange negotiating price with health plans. We were under the impression that the entire small group and individual markets, respectively, if not merged, will be regulated as a single risk pool, and therefore pricing will not vary in and outside of the exchange. Could the speakers please comment on this? And let me turn first to our insurance commissioner. Jane?
I'm trying to understand the question about meaning within the exchange that the small group and the individual would be treated as one.
The question is will pricing, they were posing that because the insurance market rules are to be the same inside and outside of the exchange, that pricing would not vary in and out of the exchange. So how would you, in the exchange, potentially negotiate with the health plans? Oh, yeah, that's a complex question. I'm going to let one of you tackle it if you understand it.
Well, I think it assumes that you'd have one pool, and I'm not sure you necessarily would. I'm not, states would have the decision about whether to merge markets and how to pool. And I do think that is one of the issues about the standardization and the need to know more information. But there's still the opportunity, I think, in the exchange to put conditions on quality and the kinds of delivery systems, patient-centered medical homes that you may not have in the general rules governing the total market. That said, again, how do you add those requirements and achieve your affordability goal?
Perhaps the example from Massachusetts, which is only one model, might be helpful in terms of answering this question as well. Massachusetts only contracts with selected plans with its exchange. Therefore, when the plans offered bids one year and they were what the executive director and the board felt to be too high, they said, go back and give us better bids. They could do that because it was not all of the health plans in the state offering in the exchange. It was just the plans that they had a contract with to do that, and they were special plans that were offered through the exchange. Presumably their rating scheme was the same for similar types of customers outside, but that's an example of a negotiation scheme. So what I'm going to do is ask our speakers if they have a final comment, and then I have just a couple of closing comments to tell you where you can get further information. We'll go in reverse order this time. Jane, do you have a final comment from West Virginia?
No, I just think that the exchange piece is one of many aspects that have to be thoroughly thought out and vetted as we move forward with the implementation of the Patient Protection Affordable Care Act. Because, I mean, the exchange, and when you get into the contract negotiation and how that's going to play out, also plays into other moving pieces of the implementation, including the medical loss ratio, which becomes effective January 1st of 2011. So it's going to be incumbent upon us to continue to be very informed and stay abreast of all the rules and regulations and the different guidance that is coming forward from HHS as we try to pull all this together and make it into a workable solution or situation for our individual states. So, I mean, again, it's you know, it's all part of a very daunting task that we have before us. And one piece is not in isolation of the other.
Great point. The exchange can do a lot, but it is not the solution, and it's not all implementation. And to hang that on it is probably unwise, or at least a setup for not being the success that I know all states want to have. Trish, do you have a final comment?
Well, I think Jane's quite right in that it is a daunting task, but it's also interesting to see, even from this discussion today, two relatively small states, Maine and West Virginia, have pretty significant differences in how we're approaching these deliberations at this point in our discussions, which does speak to the importance of states working together and figuring out what works in their own state. I guess as a close, I would just say that while Jane is 100% right, it is daunting. It's the most exciting opportunity that state officials have had before them in my career. And I think thanks to NASHP and HRSA and groups that are supporting states, there's extraordinary opportunities to do great things for our citizens and make affordable health care a reality if we keep plugging through the dauntingness and find solutions together.
No, I think with challenge comes opportunity.
Yep.
What wonderful comments from our speakers. Let me guide all of our listeners here to the NASHP website, where there is a host of information related to implementing health reform and the number of other things that states do. So that's www.nashp.org. We have two related websites, both of which can be accessed through the main website. We have the SHAP website, www.shapaccess.org, where you can read about the activities of the SHAP grantee states and look at related resources. This is where the recording of this webinar will reside, and those who are interested in it can share it with other colleagues. And finally, let me refer you to statereforum.org, which is NASHP's reform website, where we have a host of documents that you states have shared related to implementing reforms. I mentioned early on that we had 10 strategic priorities for successful implementation of reform, one of which is be strategic with the exchange. We have a number of documents, planning documents, draft legislation, reports of committees, and we not only urge you to go there for resources, but we urge you to share with your fellow states the things that you've developed, and we will post them and make it an easy resource for you. And I guess finally, let me thank, before I thank our distinguished guests, let me thank our team here for working to put this webinar on. They're also just a terrific team to work with, and I appreciate Sonia's presentation particularly, and Chris's enormous help with this whole webinar here. Let me then finally thank very much Trish Riley, Director of the Governor's, oh gosh, I don't have it in front of me, but Director of Dirigo Healthcare, the Governor's Health Policy Advisor in Maine, and Commissioner Jane Cline, the Insurance Commissioner in West Virginia, for your time, for your leadership, for your insights, for your recognition of opportunities in the face of challenges. Thanks so much, and thanks to all of our participants for being with us today. We hope you learned as we did. Thank you. Bye-bye.
Thanks.
Thanks.